It's a pleasure to be here, and I first want to thank you for the invitation to have me here today. Thank you to the Women's Health Network for allowing me to present. And today I just want to speak a little bit about breast cancer, and in particular breast cancer in Jamaica as we are seeing it. As you know, it's Breast Cancer Awareness Month, and one of the things that we want to do is really to increase the awareness in the population, in our population, about breast cancer. Now, when I do these presentations, it's really not to alarm or to bring any unnecessary anxiety. It's really for us to be informed, to be educated about breast cancer. And I think that once we are empowered, educated and empowered, we can take the necessary actions. Do I have a control, or is it? We can proceed if we. Yeah. So essentially, breast cancer is really a group of diseases. We used to think about it as a single disease, but we know it's a group of similar diseases where there are abnormal cells in the breast that have developed the ability to evade the usual control mechanisms of the body. They develop the ability to invade nearby structures, and they can spread to distant organs as well. That's pretty much what breast cancer is. Now, we know that is the most common cancer in women worldwide, over 2.2 million cases in 2022, and this is from Global Cancer Observatory. Specifically for us, though, the burden of the disease is greater in developing countries, because even though the incidence, the number of new cases per year is less for the population, the death rate from breast cancer is disproportionately higher in developing countries. Many reasons for those, I will highlight a few of them, but the burden is greater in our population, so we have to do even much more than in other areas. So specifically, I'll mention a few things about Jamaica. Now, when it comes to October, one of the things I used to see a lot of is 1 in 8, meaning that 1 in 8 women will develop breast cancer in their lifetime. Now, that figure does not relate to us. That's really a North American figure. The figure in our population is actually 1 in 15, or 7% lifetime risk. So 1 in 15 or 7% lifetime. So again, our incidence is less, but the mortality from breast cancer in our population is 2 to 3 times higher than what is seen in North America. So even though you might look at the figures and see that their incidence is higher, we are getting more deaths, relatively speaking, from breast cancer in our population. Now, I looked at the figures from 2018 to 2022. Projections from the World Health Organization is a significant increase in breast cancer in developing countries, and we're already seeing that, about 35% increase from 2018 to 2022 in terms of the Global Cancer Observatory estimates for Jamaica. Regarding symptoms of breast cancer, I just want to mention here that the majority of patients with breast cancer, when it is very early, there are no symptoms. And that is the stage at which we want to be diagnosing breast cancer, when it is very early. Because those patients do a lot better in the long run in terms of their overall survival. The types of treatment that is required is less morbid, less disfiguring, cost less, and the patients live longer. So that's when we want to diagnose breast cancer, when there are no symptoms. So how do you diagnose breast cancer when there are no symptoms? You have to screen. So this is where screening mammography and ultrasound and MRI, if necessary, comes in. We want to diagnose breast cancer when there are no symptoms. In Jamaica, over 90% of our patients, when they present, there's a lump in the breast already. Over 90%. Now, when I was doing my fellowship training, one of the things that amazed me was that we were seeing 70% of patients presenting from screening detected breast cancer diagnosis. 70%, and this was in New York State. Only 30% of patients were presenting with a lump in the breast. And that's one of the reasons why, if you look at the literature that comes from these places, you will see they're saying that the breast cancer mortality rate, the death rate from breast cancer is decreasing. And you might be misled to think that that is a global trend. It's not. The breast cancer mortality rate in the Caribbean is actually increasing, and has been increasing over the last 25 years, because we're not diagnosing breast cancer this early. So it really was, a little bit of a shock to me to see breast cancer being diagnosed that early, knowing that I'm coming back into a situation where over 90% of our patients are being diagnosed with a lump. So this is the most important thing I think that we need to change, is the stage at which we are diagnosing breast cancer. We really want to be diagnosing on mammography. I won't spend much time on the phone, but just to say here, I do have patients who will say, "Doc, here's my photo, you can use it for educational purposes like this." It's not to bring any shock to anyone, but we do see women commonly presenting like this. And one of the things that I try to do is to look at the data that we see locally. And about 40% of our patients are presenting with lumps in the breast. Not just lumps in the breast, but advanced breast cancer, as I showed on the photo. 40% were presenting like that. And that is what we call locally advanced or stage 2 breast cancer. We don't want to be diagnosing breast cancer at that stage. The mortality rate is very high. Many of these women end up losing their breasts. They need intensive treatment, chemotherapy, radiation therapy, etc. Very, very expensive therapy. So we don't want to be seeing breast cancer at that stage, but we're seeing 40% of all patients presenting like that. We can move on. So I just want to spend a few minutes talking about risk factors for breast cancer. Now, when we talk about breast cancer, we don't speak so much as direct causation, we talk about risk. What are the things that can increase the risk in an individual and therefore in the population of developing breast cancer? There is a complex interaction between the genetic or hereditary factors, hormonal or reproductive factors, lifestyle and environmental factors. But some of the ones that we know are associated with the greatest risk: increased family history. Now, if you have a single first-degree relative, that's parents, siblings, or offsprings, doesn't matter the sex, with breast cancer, then your risk approximately doubles. And the more first-degree relatives you have with breast cancer, the higher the risk goes up. In persons with genetic mutations, their risk of breast cancer is significantly elevated. For example, the so-called BRCA gene mutation, if you have that mutation, your risk of breast cancer is 70 to 80% lifetime. Remember, I said at the beginning that the risk of breast cancer in our population for the average woman is 7% lifetime. It goes up to 70% with these genetic mutations. And there are other things we mentioned. We speak about the fact that women who have never been pregnant, those who delay pregnancy later in life, there's an associated increased risk with these persons. It's a slight individual risk, but in a population that is multiplied, and that increases the risk in the population. Equally as important are lifestyle factors. Now, obesity is one of the things that we have noted to increase the risk of breast cancer by 50 to 100%. So it almost doubles your risk of breast cancer. So we advise women about obesity in adulthood, having an active, healthy lifestyle. Weight loss is important, avoiding alcohol abuse and smoking. So these are things that we can do to decrease the risk of breast cancer individually and within the population. Okay, we can move on from that. I won't spend too much time here, but just to highlight the reason we are seeing increased breast cancer mortality in our population. And we studied it, and we found that we are seeing breast cancer in much younger women. Average age of breast cancer diagnosis in our women is 54. And let me just say here that we see breast cancer in men too. 1% of breast cancer occurs in men, so it's far more common in women. But when we see breast cancer in men it tends to be at a later age, about 68. So men are more dependent on family members and so forth to take them to their consultations. It's diagnosed later. The default from follow-up and treatment is extremely high in men. I've seen men with breast cancer and they will just not come back. They say, "Doc, I'm going to try something else. This is not for me." And some men just don't think breast cancer can occur in men. It's a female disease. It's not. So I just wanted to mention that. But in our women, the average age was 52 to 54, much less than in the US, where it is 62. So we need to be mindful of that. We have a lot of young women with breast cancer, a lot of women who the treatment of breast cancer will impact their ability to complete their desired childbearing. And that's a discussion that we have to have a lot of times, because we see breast cancer in women who are still in their reproductive age group, in the prime of life. Right? A lot of these women, also on the younger side, may not have access to finances such as insurance. They're not as stable in their jobs, they're not as stable in their relationships. It's a big toll on the young women that we see. So some of the other differences we saw was that the cancers that we were seeing in our population were more biologically aggressive. They had higher grade. We had twice the rates of the triple negative subtype, which is an aggressive type, in our population. And of course, as I mentioned, we're seeing patients presenting at a much later stage. This is very important for us to understand, because what it means is that when we, on average, when we see a Jamaican woman presenting with breast cancer, off the bat, it's usually more aggressive. Later stage of diagnosis, more likely to be triple negative. So we're already up against it at the time that we made the diagnosis. So when that patient now enters the healthcare delivery system, we need to have a system in place that is really equipped to manage that patient, because we're already seeing a patient who is at a higher risk of succumbing to that disease compared to what you will read when you take up a paper coming out of North America. So that is something that we are now aware of. And what we need to do is to bring the healthcare delivery services in line so that we can offer the best, most effective treatment for these women. What that means is that we need to have comprehensive cancer treatment facilities. We do not have that in the Caribbean, but that is where we need to go. And even though we don't have that, we need to start looking at how can we, maybe put the trained personnel in place to make these changes. So I'll just segue here. One of the things that we did was to set up a breast oncology clinic at the Kingston Public Hospital, where we're now able to dedicate and offer a dedicated space to women who are diagnosed with breast cancer. So we have taken them out of the fragmentation of the usual clinic system to have a dedicated space available for them. And now we can offer these women an individualized multidisciplinary care. It's a small step, but I think it's an important step in terms of how we conceptualize the care of our women going forward. We recognize our own challenges when it comes on to breast cancer, some of which I've already mentioned: the patient challenges, the challenges with the healthcare delivery system, and the lack of mammographic screening. I will talk a little bit just about how we're able to treat our patients with breast cancer. The most important thing, once we've made a diagnosis, is really to engage the patient, counsel the patient that this is not a death sentence diagnosis. And I made note of the writing here by Icy Porter about breast cancer and her own personal journey with breast cancer. And it is important. A lot of women believe that breast cancer is a death sentence, and they're very fearful. So we spend a lot of time to counsel, to advise women that this is your individual diagnosis of breast cancer. And we try to find all the features of that individual patient in terms of the tumor type, the subtype. Is it hormone positive? Is it hormone negative? What is the specific stage? What is the histology? And then you craft a treatment specific for that patient. So even though they will meet other patients diagnosed with breast cancer and perhaps have been treated in this manner or the other manner, we stress that this is going to be your individualized treatment recommendation, unique to you, your desires, and the type of breast cancer that we have diagnosed in you. And we try to get the patients to understand this, because once you understand this, that's the first hurdle when it comes on to your treatment. Treatment can be intense, as I mentioned before, usually multidisciplinary, sometimes requiring chemotherapy, sometimes requiring radiation therapy, sometimes requiring hormonal therapy, and sometimes advanced targeted therapy, which is extremely expensive, almost always requiring some form of surgery. In Jamaica now, a diagnosis of breast cancer doesn't automatically mean that you need a mastectomy. In about half the patients that we see, there is the possibility to conserve the breast, remove the tumor from the breast, and preserve the patient's breast in its normal shape and contour. So this is something that can be done now, but again, I stress that the patients have to present early enough. Last thing I want to mention is about support for breast cancer. And let me again express my gratitude to the Women's Health Network. They have actually come on board with us at the Kingston Public Hospital, and they have provided support. In fact, they're there in October this year, providing counseling, camaraderie with our patients. Also recently, Dr. Stevens led an initiative to provide us with our own ultrasound machine in our clinic that we're able to do our biopsies in a more timely manner, so we can decrease the time to make diagnosis when it comes on to breast cancer. I'll also mention here the Jamaica Reach to Recovery Group, which is the breast cancer affiliated survivors group of the Jamaica Cancer Society. They also come to our clinic once per month to fellowship with our women, and they do provide financial support as well. Sometimes when our patients can't get certain scans done, we rely on them to assist us. So I just want to say thank you to the support groups that support patients with breast cancer. And there are more that we can do. Sometimes they do need volunteers, they need donations as well. I know the Jamaica Reach to Recovery has a pink run the last Sunday of this month. So please support them as well. So thank you very much for your time and your attention. I just wanted to highlight a few things about breast cancer that we are seeing in the Jamaican population. I think the more we understand the unique factors about the patients and the cancers that we're seeing, we're much better able to treat our patients and to increase the survival in our country, so that we can talk about improvement in breast cancer survival like it has been done in other places. So thank you again. Morning, church.
Are there any questions? Are there any questions for Dr. Copeland? No? Can we get a mic, please?
Oh, the question is, when do you stop taking the mammogram? Yeah, so very good question, and let me just say, when it comes on to doing mammograms or screening for breast cancer, we want to do more risk assessment, assess the individual risk. So if you're over the age of 30, you can get an individual assessment of your risk done. 7% is the lifetime average in Jamaica. But an individual may come to you, and when you do the risk assessment, you find it's 15% or it's 20%. And you're able to tailor an individualized screening recommendation for that patient. Usually, if it's an average risk, we start the screening at 40, and we do it every year with mammogram. We may add ultrasound, and once you are healthy, you can continue that mammogram almost indefinitely. We usually stop, and most of the recommendations will stop at age 70. But if you come at 70 and we look at you and we do an assessment and we say, oh, but you are so healthy. You know, women who live to 70, 75 on average live another 10 years or so. We may elect to continue that screening because the benefit outweighs, any potential risk. So that is in terms of where we'll stop. Now, there's another group when we do the risk assessment that the risk might be extremely high, and we may elect to start that screening much earlier at age 25 rather than 40, and we may add MRIs rather than just mammograms. So that's when we'd stop, that's when we'd start, and that's how we do it, and how we should be doing it now, more about risk assessment and understanding the individual risk. Thank you for that question.
Good morning, brothers and sisters. You spoke about keeping the breast in shape and form. It's just yesterday while going home. This person was talking to me about one of their member of the family, young girl, only 33. And she died of breast cancer. Why? She's a mother. She died leave a 10 months old baby, and she has 2 before. I was told, keeping the breast in shape and form, she refused to breastfeed. Yes?
She refused what?
To breastfeed. Yes, because she wanted to keep the breast in shape and form. And that's what gave her the cancer. It happened with the first child when they took her to the doctor and they did whatever they did. They said the breast was, whatever came out was thin. But she still proceed and continue keeping that milk because she wanted to keep the breast in shape and form. I don't know if you doctors have come across anything like that, or you want to add to your females the list when they come that if you're a mother, it's God's way to breastfeed because in the end you will lose your life. Thank you.
Thank you for sharing that. We do see a lot of young women with breast cancer. About a third of the patients that we see with breast cancer in Jamaica are under the age of 50. Tend to be more aggressive in that age group, much more likely to be that aggressive triple negative type. So as I mentioned, there's a special focus that we need to have when it comes down to breast cancer in young women. Now regarding breastfeeding that you mentioned, yes, there is an increased risk of breast cancer in women who don't breastfeed or breastfeed hardly. Now, when I say this, I don't mean that it is the cause of the cancer, but we have recognized a slightly increased risk, and this is based on study of populations. So the individual risk is small, but if you look at a population of women who don't breastfeed versus a population of women who do breastfeed, you will have more cancers being diagnosed in the group that does not breastfeed. So something that we have recognized that there is a risk associated with it. But like many of the other risks, we don't tell women that you're going to get breast cancer because of this or that, because of a very complex interaction of all the different risk factors that I mentioned before. But yes, it's one of the things that we've recognized as an increased risk factor for breast cancer. So we advise breastfeeding. We always do.
Good morning.
Morning.
Why does the mammogram hurt so much?
Right. I wish I could answer that question very definitively, but there are times in a woman's menstrual cycle when the breast becomes extremely sensitive. And perhaps one of the things that you can do is find that time in your menstrual cycle. We usually recommend just after the menses has ended, where the breast is less engorged, usually less tender, and it is easier to be viewed on the mammogram as well. But yes, there are some women who says, boy, doc, they really don't like it. Most women will say there's some discomfort. But I have a lot of women who come and say, Doc, I did not know it was going to be like this. I thought it was going to be painful. I thought it was going to be this, and I was so scared. So the majority of women don't have a painful experience, and that is true. The majority of women will not have a painful experience. But like in everything else, there are some women who do. And unfortunately, I think that becomes magnified sometimes within the discussions. But perhaps for that individual person, you find that time of the month where the breast is not as sensitive to perform the mammogram. But there are other things that can be done, either usually as an adjunct to the mammogram, not to replace it, but for example, breast ultrasound to give us additional information, breast MRI for additional information, and even now, in some places, breast CT scan. So these are adjuncts to the mammogram as well that can be done. But I'm sorry, sometimes the mammogram can be a bit uncomfortable. Well, thank you. Yes, sir.
You said the risk seems to increase with breastfeeding. Does breastfeeding involve direct...
No, the other way. Other way. Decreases.
Decreases?
The risk decreases.
Oh, I'm sorry. I thought I said it increases.
Yes.
Direct feeding or expressing the milk, is there a difference in the risk factor there?
Right. So the studies that looked at it actually spoke about direct feeding. I can't say anything has been looked at with just expressing, but direct feeding is what was looked at. And actually, not just an arbitrary direct feeding, but looked at the time of feeding. And the time of feeding is 12 months. So on average, time of feeding of about 12 months cumulatively decreases the risk. But no, I didn't say anything about just expressing. It was really direct feeding.
Okay, good morning. I also have a question. Good morning, church. Unfortunately, my mother died of breast cancer. And so my concern now is, at what age should I prioritize going to the doctor and getting mandatory checkups, considering that it's hereditary?
Thank you. I'm sorry about your mom dying of breast cancer. There is an individual assessment that you will need to get done. One of the things that we look at is the age at which your mom was diagnosed. Typically, if she was diagnosed under age 50, and there are other factors as well we look at, we'd usually recommend that a genetic test is done. Now, if she did not have the genetic test done, then we could advise you to have the genetic test done. So we look and see if there's a mutation that might have been passed on. If that mutation is there, then we'd recommend that your screening would start much earlier, age 25 to 30, mammograms and MRIs. If the mutation is not present and mom was diagnosed, much early, we look at her age of diagnosis, and usually we'd say you start 10 years prior to her age of diagnosis. And of course, we'll do a specialized risk assessment for you, look at your individual risk, and then make that recommendation. So those are some of the things that we want to find out a little bit more, and then we could say, for sure, you're going to start at 25, or you're going to start at 30, or you're going to start at 40. For example, if mom was at 60 when she was diagnosed, we'd probably say, we look at your genetic test results and make a recommendation. It could be 40, it could be 30, it could be 25. So a lot more information will be required, and that can be discussed, and then we'll give you an individualized recommendation. Thank you.
Okay. Thank you. Thank you, Dr. Copeland.
Thank you guys very much. Thank you for the questions.